Assalamu alaikum and good morning. After the break, we'll be having our second lecture on pituitary disorders. And in the previous lecture, we covered growth hormone excess, or whether it is in the adult when it is manifested as acromegaly, and then if it is in early childhood, then it develops as presents as gigantism. Now, today we'll be again continuing on with the growth hormone disorders of the pituitary, and this is how we'll be covering out in, like, as usual, in a case scenario format. Now, mother brings her 15-year-old son to the OPD complaining of that he is not gaining height as compared to his other sisters and brothers and his classmates. So he's depressed. He's because of being always being made fun of his height, and he's depressed. He feels socially isolated. He's 3.5 feet tall, along with thin skin. There are wrinkles on his skin, particularly on the face. His decreased body tone, and his mother complains of his unsocial behavior at home and lack of interest in studies. Now, when someone does not gain height as, say, compared to his siblings of same age, or his other children of the same age, you have to have a differential diagnosis. Now, the differential diagnosis of someone who can be called as short for his age, or not has attained the same height as it should have been predicted as compared to the heights of the parents and heights of the siblings, then the following differential one by one should be considered. Sometimes it has to be considered as a familial short stature. If both parents are of short stature, they can't expect that the height of the child would be different from that. So that factor has to be considered whenever we are talking of a short stature person. Sometimes there is a constitutional delay that as you grow old at the puberty, there is an increased surge of certain hormones, which includes both gonadotrophic hormones as well as the growth hormone, and all these may have some slight delay, and some people may start gaining height maybe at the age of around 12 or 13, rather than the usually the height gain, which maybe at the age of 7, 8 or 10 years. Growth hormone deficiency can be the most say common cause considered for this short stature. Sometime it may be related to bony structure or bony skeleton disorder like achondroplasia can be a reason for a short stature. Vitamin D, which is responsible for growth of the bone and bone health, can be a reason for short stature. As we already mentioned, sex hormone deficiencies, the testosterone and the gonadotrophins for female FSH and LH may also be responsible for, and estrogens, they may be responsible for not attaining the usual height and strength. Now, when you talk of a dwarf, you usually have to see it that whether this dwarf is proportionate or is disproportionate. A proportionate dwarf would mean that his body structures, the torso and the limb has a very proportionate type of a relationship, that both torso and the limbs are smaller, right? And these people would be having all just as if like bonsai, or a smaller version of the grown-up adult individual. The rest of the things would be proportionately short. But in disproportionate, you may have two variants. Sometimes you have people who have normal or larger trunk, and their limbs are short. Now, this is usually in a patient with achondroplasia, and the other person where the limbs are all right and their central body torso is short. Now, this is important that in growth hormone deficiency, usually you have a proportionate type of a dwarf, and in achondroplasia, you may have, say, this limbs short for the trunk and disproportionate dwarf, and similarly in other disorders which may be pertaining to skeleton, you may have a disproportionate dwarfism. Excuse me. Now, today we will be primarily focusing on growth hormone deficiency. Now, growth hormone deficiency can be congenitally there when, particularly when the child presents in early recurrent hypoglycemia in the infancy, and then they are have a short stature starting from the very early childhood. Then you may have an acquired growth hormone deficiency, which may result from either radiation to the pituitary area or to the brain, or maybe pituitary being compressed by a mass, or pituitary being damaged because of a trauma or hemorrhage or bleed. And in this case, after an initial normal growth, the person may start showing signs and symptoms of growth hormone deficiency. And again, the growth hormone deficiency signs and symptoms would vary. They would be different if the growth hormone deficiency starts in very early childhood, and the symptoms and signs may be different, vary when it starts in someone who has already attained the normal growth and height, but other body structure would show the sinus deficiency, which we will be talking about in a moment. Similarly, the growth hormone deficiency is not always absolutely complete. Sometimes you may have a partial or some slight hormone deficiency, and sometimes it may be totally absent or deficient growth hormone. And again, the symptomatology would vary from a person who has a total deficiency of growth hormone to a person who has some partial deficiency of the growth hormone. The signs and symptoms of growth hormone deficiency again may be this is the picture of probably through Guinness Book of World Record told to be the shortest individual in the world at the moment from India. The signs symptoms, if it starts in the very early childhood or during infancy, the growth would be retarded as a whole, as a total. Sometimes they may show some signs of a central obesity or say pot belly. They may start with psychogenic symptoms, more of a being making a laughing stock, and maybe because of not being able to say fit in their class along with their class fellows or their peers. They would have a decreased bone and muscle mass. Their skin is usually thin and fine and wrinkled. There is lack of sweating, and of course, this also leads on to poor temperature regulation, and they do complain of often on maybe sometime low-grade fever, or sometime maybe presenting as not being able to cope with the cold temperature. They have decreased energy and endurance. They have overall low energy levels, both physical and psychological, as well as mental energy. Their cholesterol and LDL are usually raised. They do have some increase in systolic blood pressure. They have say restricted or low cardiac output, and of course there is an increased production of insulin in them, which further results into hypoglycemia and other manifestations. When you are checking for growth hormone deficiency, as we said that growth hormone is a dynamic type of hormone which varies with the does have diurnal variation. It is level may be low in the evening and high in the morning. Level may vary with diet intake, level with the hypoglycemia or hyperglycemia. So many things has a effect on the growth hormone level, that checking the growth hormone level for its deficiency or excess is not usually say wise, and it is the IGF-1 levels which are not dependent upon the food intake or glucose level or the time of the day. It is more appropriate to check for the low IGF levels. Similarly, we did talk about that whenever there is a deficiency of the hormone, you try to stimulate it. And the stimulation for the growth hormone is hypoglycemia. That the low blood sugar level gives a signal to the hypothalamus and then to the pituitary to increase the growth hormone secretions. Now, if this hypoglycemia fails to raise the growth hormone level, that means that the pituitary does not have the reserves to increase growth hormone. And this hypoglycemia is usually induced by giving insulin. And of course, you check the blood sugar level, then you give 4 to 6 units of insulin and keep on checking repeatedly the blood sugar level. And when the blood sugar level falls below, at that time you take simultaneous blood level for both glucose as well as for the growth hormone. And at a level of hypoglycemia, there should be an increase in uh, growth hormone level. Now, there is a word of caution about this test being performed, that it should be avoided in patients who have either seizures or who have coronary artery disease, because this induction of hypoglycemia can precipitate fits in those with the seizure potential, and similarly, the hypoglycemia would lead on to other sympathetic overdrive by the bodies, and can lead on to tachycardia and sweating, and may also induce ischemia of the coronaries and may lead on to precipitation of angina or of a myocardial infarction. So, with these two groups being say avoided, the low IGF level or insulin tolerance test would be the test of choice for assessing the growth hormone deficiency. Another test which can be done, and which would be that we know that and the second stimulus for the release of growth hormone from the pituitary comes from hypothalamus in the form of growth hormone releasing hormone, or we also in the previous lecture noted that arginine stimulates the uh, secretion of growth hormone. So if giving someone growth hormone releasing hormone or arginine stimulation should lead on to a rise in growth hormone level, provided the pituitary is able to secrete growth hormone, and the cells producing growth hormone have not been destroyed or damaged in any way. Again, even this test has to be carefully done in patients who have kidney or liver disease, because it can lead on to an increased, say, uh, damage to the kidney, and can the arginine or GHRH may not be excreted with the kidney, and a raised level may be damaging to the further to the kidneys. There is a autosomal recessive disorder by the name of Laron syndrome, and Laron syndrome it results from mutation in the gene for growth hormone receptors, meaning by that the growth hormone level is okay, it is normal, maybe super normal, and it is secreted normally from the pituitary, but the growth hormone receptors which are responsible for release of insulin growth factor 1 or IGF, insulin like growth factor 1, they are say deficient, and this deficiency lead on to poor release of IGF-1, right? Now this insulin like growth factor deficiency would be that this patient, in addition to having signs and symptoms of growth hormone deficiency, they would also show resistance to diabetes, meaning by that since insulin like growth factor or insulin effector are absent, so they would not show up the diabetes. These individuals with Laron syndrome usually present either with dwarfism, they do have a depressed nasal bridge, their mandible is underdeveloped or receded, they do have central obesity, and sometimes they may present with hypoglycemic sears. Uh, this is the biosynthetic IGF-1 before puberty is possibly the treatment of such individuals, that this IGF is injected or given, say, externally, as their liver cannot produce IGF in response to growth hormone. Now, again, this is one of the picture which was taken some time ago in Melbourne River Yarra. You travel across Europe or you travel across the most of the Western world, on most of the bridges or the rivers where you find these rails or railings, you would find these locks being, say, placed over there. So what it is usually that the couples who are in love, they make a statement onto this river, and they, as a token of their love for each other and to remain each other, they put a lock onto this string and throw the key into the river or the lake or whatever is there, and supposedly that they have locked themselves in a sort of a love relationship. But I we don't know that whether this is truly so that they remain so, or a few years later they are locking their love with someone else with another lock being posted over there. This still remains to be, but this is a very common scene in Western, say, river bridges. Now, we'll go on to another case scenario. The numbers are as per pituitary disorders in total, starting from the initial two scenarios as well. A 54-year-old man underwent a transsphenoidal surgery following history of tonic seizures for the diagnosis of pitch tumor in 2001. Right? Uh, 6 months after his surgery, which was declared as successful, uh, he was reported to his general practitioner, which complained of fatigue, lethargy, decreased exercise capacity, dry skin, decreased sweating. He had become more and more depressive, impaired social gathering, social functions, and he possibly uh, avoids attending parties or being in groups, and has low self-esteem. So the GP made a diagnosis of depression and started him on serotonin noradrenaline receptor intake inhibitors, and they were started. 3 months after this initial reporting, which we started 6 months after his surgery, he then started complaining of decreased libido, impotence, and decreased body hair. So next 1 year, he complained of cold intolerance, dry skin, mental dullness, constipation, and hoarseness. And the next few months, he developed weakness, nausea, vomiting. He felt anorectic all the time. He started losing weight, uh, complained of low-grade fever all the time, and he also noticed that he gets dizzy on standing up, which was labeled as a result of postural hypotension. And then quite a few hypoglycemic spells were reported. And the other thing which he noted is that complexion started getting more and more fair as compared to what he was before the surgery. On examination, we found him slightly overweight. He had fine, pale, and smooth skin with fine wrinkles on the face, uh, and there was a deficient or absent axillary and pubic hair. He had atrophy of genitalia, particularly the testicular atrophy, and had decreased muscle strength, had a postal drop of blood pressure of around 20 millimeter of mercury. His heart rate was slow though, and he has delayed uh, deep tendon reflexes. So, what's the diagnosis? This was not his picture. This was a picture that he resembles. Uh, this you can notice loss of hair from the mustaches and from the beard. This is a picture of panhypopituitarism, right? And why it happened? Because that if you go back to the picture of pituitary again, the posterior pituitary mainly produces the ADH, which is responsible. Its deficiency would lead on to polyuria, polydipsia, hypernatremia, lethargia, dehydration. Then the anterior pituitary, the main hormones are growth hormone, LH and FSH, thyroid stimulating hormone, and ACTH. ACTH produces cortisol, stimulates the adrenal to produce cortisol. In fact, now deficiency of ACTH would result in hypoglycemia, maybe vomiting, maybe malaise. Deficiency of TSH from the pituitary would lead on to deficient production of thyroxine, and this deficiency would produce symptoms like fatigue, constipation, cold intolerance, and bradycardia. Similarly, the lack of luteinizing hormone and follicle stimulating hormone from the pituitary, depending upon male or female subject, would be deficiency symptoms. In females would be deficiency of estrogen, delayed puberty, and amenorrhea, and in male there may be lack of say testosterone, and all the muscle strength and all that will be lost. Similarly, the growth hormone deficiency, depending upon in which age it starts, may be presenting with hypoglycemic show stature in the early childhood, and deficiency of this may then lead on to again the in the sex steroid hormone deficiency, may lead to testosterone, micropenis, or delayed puberty. The labs of this gentleman, which we described, who had undergone a pituitary surgery, and then that pituitary surgery resulting in hypopanhypituitarism. He showed anemia, he had hyponatremia and hypoglycemia. His all low free T3 and free T4 and TSH were low. ACTH and cortisol were low, and similarly there was low levels of follicle stimulating hormone and luteinizing hormone. Right. The most of the time, the reasons or causes of panhypopituitarism are can be either head injuries or head injury leading on to crushing of the pituitary, or disruption of the blood supply to the pituitary through trauma or pressure. Sometimes tumors lead on to pressure effect onto the pituitary stalk or maybe the pituitary itself, and they can be a reason, or even the tumor rising from within the pituitary can lead on to compression of all the say hormone producing areas of the pituitary and can lead on to hypopituitarism. As in our patient, this was the brain surgery, or which was responsible for radiation to the say brain or head for any other say treatment. It can be a reason for panhypituitarism. There are patients who may develop autoimmune inflammation of the pituitary, which will be called as hypophysitis, or autoimmune deficiency of the pituitary. Sometimes it can be a result of a stroke or decreased, say, um, deficient blood supply to the pituitary area by the artery supplying it being blocked as a result of clot or embolus. Uh, Even infection of the brain, such as meningitis or encephalitis, may involve the pituitary and can lead on to long-term pituitary deficiency. And not to forget that sometimes tuberculosis can be a reason for this. The signs and symptoms of panhypopituitarism, as already described in our patient, they usually are progressive, right? Although the signs and symptoms can occur suddenly, usually they tend to develop gradually. They are sometimes vague and subtle and may be overlooked for many months or even years. Like in this patient, they were considered as a manifestation of depressive illness rather than any other, right? Uh, the signs and symptoms, of course, would depend on which hormones are deficient. They may be in the form of fatigue, headache, low tolerance for stress, or muscle weakness. They may feel nauseating all the time. The constipation as a result of say, secondary uh, hypothyroidism. Similarly, weight loss again because of the same reason, and a decrease in appetite. The symptoms usually are in the form of abdominal discomfort. They feel intolerance to cold, and they have difficulty in staying warm. They may have visual disturbances again, depending upon if it is panhypopituitarism is caused by an ever-growing mass in the region of the optic chiasma. They have loss of the axillary and pubic hair. They may complain of some joint stiffness. Their voice would become hoarse. Some degree of facial puffiness may be noted, and they may also complain, depending upon if the posterior pituitary is also involved. There would be increased thirst and excessive urination because of the lack of antidiuretic hormone. Their blood pressure would be low, both because of the lack of cortisol, lack of loss of water, and they may complain of postural giddiness or postural hypotension, lightheadedness on standing because of loss of volume and because of loss of the regulatory mechanisms. This again is just a summary of that from in a head to toe examination of a patient with panhypopituitarism. Their scalp hair may be very scanty. They may show some degree of ocular palsies depending upon the site of the tumor or mass, if it is cause of this. Skin is wrinkled. Sometimes they may have a previous signs of acromegaly or Cushing's syndrome. We did describe in the previous lecture that in acromegaly you may have a growth hormone secreting tumor or microadenoma, which may be excreting more of a growth hormone, but would be suppressing the rest of the cells to produce any other hormones, and thus they may manifest as panhypopituitarism. Lack of hair in the axilla and in the pubic area is usually there. Their skin is usually dry, pale, and fine. They may have atrophic testes. There may have a scar of a previous surgery, like in our patient. They may show optic atrophy and may bitemporal hemianopia if it is tumor is in the region of the stalk. Sometimes galactorrhea may be a manifestation. Some pallor of the nipples, hypotension, as I said, female type of a fat distribution. They may have loss of muscle bulk, and there may be increased if gonadotrophin failure is alone, and decreased if the growth hormone failure is there, right? Right. So again, we just repeat that the symptoms would depend upon which hormone is deficient and whether. So if the hormone lost is FSH and lack luteinizing hormone, the sign in hypogonadism is predominant in the form of amenorrhea in female. When it is lack of TSH, the sign and symptoms would be more like hypothyroidism. Lack of ACTH would lead on to adrenocortical insufficiency. Prolactin deficiency would lead on to failure of postpartum lactation. And if all of them are there, it would be called as a panhypopituitarism. And in children, the growth hormone deficiency would be responsible for short stature. How do we check pituitary function? The baseline studies would include, of course, measuring the TSH level, ACTH level, FSH level, LH level, and prolactin and growth hormone. And of course, we do say try to stimulate a deficient gland by stimulating factors. So the stimulating factor for thyroid or for this growth hormone, as we already said, would be either thyroid thyrotrophin releasing hormone, which releases TSH, or luteinizing hormone releasing hormone, which is responsible for release of FSH and LH from the, and of course insulin induced hypoglycemia, which would be responsible for release of growth hormone. So an induced hypoglycemia in a normal pituitary should lead on to increase in growth hormone. An increased secretion of FSH in response to LH, RH rules out that there is no production of FSH, LH from the pituitary. And similarly, an increase in level of TSH would be seen if TRH is injected to these individuals. And second set of investigation would be radiological investigations, right? And this is in the form of imaging that you go for a lateral skull X-ray, which would show the pituitary fossa being either widened or maybe say some erosion of the pituitary surrounding bony structures like anterior clinoid processes. In fact, CT scan of the head and brain or MRI would be more informative as compared to simple lateral skull X-ray. Now, the treatment of hypopituitarism would be that we probably remove the cause. This cause, which means that if we find a say tumor which is responsible, like a macroadenoma is responsible, you remove that, and of course expect that the removal of pressure effect from the surrounding pituitary tissue would lead on to restoration of the function. Then if that cannot be done, then we have to go for the replacement therapy, that all those hormones produced from the target glands which are deficient are to be replaced. For example, you might have to give thyroxine because of the patient has secondary hypothyroidism. You have to give hydrocortisone for secondary hypoadrenism because ACTH is lost and there is decreased cortisol level. So usually we give 20 milligram of prednisolone in the morning and 10 cortisol in the morning and 10 milligram in the evening. If we are treating growth hormone deficiency, particularly with the panhypopituitarism of children, the growth hormone will have to be replaced. Testosterone monthly injection in men would restore a lot of sexual drive or libido. Estrogen progesterone combination would have to be given for females to restore their normal menstrual cycles. And if we want to induce ovulation, of course, then FSH and luteinizing hormone would have to be given periodically. Now, coming back to our patient, Mr. A, which was 55-year-old male who underwent, pituitary surgery and then developed panhypopituitarism, was treated with the prescription of thyroxine 200 microgram daily, prednisolone 7.5 milligram per day, 5 milligram in the morning and 2.5 milligram in the evening. He was prescribed injection testosterone 250 milligram intramuscularly every month. Over next few years, we started off following him in quite earlier on, and he also developed diabetes mellitus and was put on premix insulin. He needs his dose adjustment for his both insulin as well as for other medication, because he usually whenever he has upper respiratory infection or other infection. He's under follow-up for almost 20 years now. And last year he underwent a laparoscopic cholecystectomy under GA and is doing fine. Now this is pan-hypopituitarism, whether it develops in, say, early childhood, leading on to short stature dwarfism, or develops in later in the life as a result of, right? Now this is again one of the, say, famous tourist site in near Sydney in the area of Blue Mountain, and this, I don't know, it is just say three, say, barren rocks like structures named as Three Sisters 1, 2 and 3, and then this sort of a national park where it's a very famous say tourist attraction sites. Now we go on to our next case, and next case is a 30-year-old lady who reports failure to conceive after her first childbirth, which was 5 years ago. So she had a delivery 5 years ago, and for next 5 years she has been unable to conceive again. Her mother-in-law reports that she had a heavy postpartum bleeding when she had her first delivery or child 5 years ago, and following that delivery, the first thing which they noticed was that she did not lactate, and her baby had to be started on formula feed. She also describes multiple episodes of fainting on standing from sitting, has become isolated and uninterested, and she has lost 8 kilograms of her weight and has amenorrhea since the last childbirth. What's the diagnosis? This is again some kind of failure to conceive and then loss of this lactation and then weight loss and then fainting and all that. This is a serially developing features of pan-hypopituitarism, but this time instead of say surgical intervention, this appears to be something different. Now, this is a classical Sheehan syndrome, pan-hypopituitarism, which results from pituitary necrosis following postpartum hemorrhage. In fact, since it was initially reported in patient with postpartum hemorrhage developing shock, and in a shock state there is decreased blood supply to the pituitary, and this leads on to pituitary necrosis. It can happen in other say acute illnesses as well, but most commonly it is the postpartum hemorrhage resulting in hypotension and shock, and which results in pituitary necrosis. And then the manifestations of this results from a serially declining pituitary function and loss of pituitary mediated target hormone being deficient. Pituitary apoplexy is another term which usually used, that it is any hemorrhage or ischemia which leads on to an acute pituitary infarction present with an acute loss of pituitary function. The causes may be that if there's a large pituitary adenoma which becomes say itself start getting necrosis as a result, or hemorrhage occurs into it, as we described. Postpartum hemorrhage presenting as Sheehan syndrome can present with apoplexy. Radiation, diabetes, anticoagulation, disseminated intravascular coagulation, or acute reduction in intracranial pressure, they can all be a reason for an acute pituitary necrosis resulting in acute pituitary hormone deficiency. They would present with an acute onset of headache, vomiting, signs like meningism, visual disturbances, and sometimes cranial palsies as well, depending upon the hemorrhage putting on pressure on the adjacent nerve exiting from the brainstem. MRI may show high intensity signal T1 and T2 weighted images in the pituitary area. And there may be history of say any of the above findings, and if dealt with early, that you remove that tumor or remove that clot or remove that hemorrhage is present under the pituitary, you may have very fruitful results, and there may not be neurological deficit, right? But then those with no neurological deficit may have been maybe managed on conservative treatment. Now this is again a lateral view of MRI, right? And this is what we have. We have T1 and T2 weighted. So this is the area where the infarcted, or this has become hyper intense signal from the pituitary area. And in normal T1 images, T2 images, it looks like an infarct, right? So when the fluid T2 weighted images, the fluid appears white, and this shows this is the fluid within the ventricles, and this is the area, the pituitary, which has become necrosed, and this is again in T1 images where fluid is as black, and this area, since pituitary tissue has undergone necrosis, so it turns out to be black. There is another say condition which is labeled as empty Sella syndrome. Now, in what is this empty Sella syndrome? This is there is an enlarged pituitary fossa due to either an acromion herniation through the congenital defect, or it may be because of surgery or radiation or infarction. Majority of the patients have normal pituitary function. It is just radiological evidence of an enlarged pituitary fossa. Pituitary itself is functioning normal, but sometimes 10% may have signs and symptoms of either hypopituitarism or maybe hyperprolactinemia. Very rarely a functional tumor may be associated with the empty Sella syndrome. Now, the case number 5 is an 18-year-old unmarried girl who presented to the gynae outpatient department with a history of primary amenorrhea, poor sexual development, poor sense of smell, and color blindness. She had no history of extreme dieting or sudden weight loss or weight gain or bulimia or rigorous exercise, which usually may be responsible for amenorrhea, and maybe anorexia nervosa is one thing which may be associated with say primary or secondary amenorrhea. On examination, her height was normal. She had normal vitals, but her breast development was uh, say not very adequate, or she had a Tanner stage 2 breast development, whereas there was no galactorrhea. Her vulva was underdeveloped. There was sparse pubic hair and prominent labia minora and flat labia majora. Now these were the findings, and the lab shows that serum LH, FSH, and estrogen were all low. Serum testosterone, prolactin, and thyroid profile were all within normal limit. Oral glucose tolerance test excluded that she had diabetes. Her karyotype revealed that she had a normal female pattern of 46XX, and MRI of the brain showed an olfactory bulbs were present, and there was no pituitary or hypothalamic lesions. Olfactory test revealed anosmia. Now this is a description of a classical Kalman syndrome, which is anosmic hypogonadotrophic hypogonadism, gonadotrophin releasing hormone deficiency. The patients, usually 42% of them do not smell properly, and they have anosmia. 25% of them may have abnormal genitalia, as in our patient. 28% may have other renal abnormalities. 50% may have some craniofacial defects, and 42% may have neurological defects, and some may have musculoskeletal malformations. Now, as we said, that if growth hormone deficiency occurs in early childhood, and the patient has say short stature or other deficiency or pen growth hormone deficiency, replacement should always be considered. But whether or not to replace growth hormone in adults who have developed all the normal developmental milestones, have attained the normal height and weight and muscle strength and all that. So whether replacing that would be beneficial or not. So there are studies which suggest that even in adults who show signs and symptoms of growth hormone deficiency, there is an improved quality of life, there is an improved psychological well-being, in the improved exercise capacity, their lean body mass increases, their fat mass is reduced, there is definite improved bone mineral density, fracture rate is reduced, which otherwise would lead on to osteoporotic fracture. There is reduction in cholesterol and improved early function. So all in all, even in adults who have shown the signs of growth hormone deficiency, replacing our growth hormone is beneficial. Of course, it must be done in children, but it should also be considered or should be done in adults showing signs of growth hormone deficiency as well. The National Institute of Clinical Excellence from UK, they have issued guidelines for the growth hormone replacement in adults. So they say that young adults who are up to 25 years of age, growth hormone should be discontinued for 3 months at completion of linear growth, which should be around 2 centimeter per year, and growth hormone should be reassessed. So in severe deficiency, growth hormone should be continued at adult dose till 25 years when they have attained their peak bone mass. And this is the replacement schedule for patients up to the age of 25 years showing signs and symptoms of growth hormone deficiency, meaning by children or adolescents. In adults who develop growth hormone deficiency, if their growth hormone level is less than 9 microunits per liter, and there is an impaired quality of life which is assessed through the AGHDA, say quality scoring of less than 11, the and they are under treatment for other pituitary hormone deficiencies, there should be reassessed periodically every 8 to 9 months. And if growth hormone is replaced, the growth hormone replacement can be discontinued if there is no improvement in AGDHA or improvement is less than 7. So this brings us to this right the end of our today's presentation, where we have considered uh, hypopituitarism, or both PAN1 growth hormone deficiency in children, growth hormone deficiency in adults, pan hypopituitarism, pituitary apoplexy resulting from an acute, say, damage to the pituitary, and Sheehan syndrome, and the Kalman syndrome, which is again an isolated deficiency of say this gonadotropin releasing hormone, along with olfactory dysfunction in the form of Kalman syndrome. Thank you very much for your patient listening, and inshallah we'll be meeting next week again.